morning, everyone, and welcome to the fourth session of the Brain Injury Association of Rhode Island's 21st Annual Conference Series. My name is Doreen Grasso, and I'm the Education and Program Manager here at BRI, and we're delighted that you can join us today for Plateau in Progress, the Impact of Spasticity on Functional Recovery After Brain Injury and Stroke by Dr. Caroline Sizer. First, we'd like to just thank our sponsors for today. Encompass, our premier sponsor, for whom we're very grateful to have. We also like to acknowledge our presenting sponsor, Marasco and Nesselbush. Also acknowledge the Department of Health and Human Services, whose funding helps BRI provide programs and resources like this for the brain injury community. Friends of BRI include Avatar, Robin Hill Farms, SpeechWorks Rhode Island, Just Ask Aphasia Stroke Knowledge Group, Roman Catholic Diocese of Providence, OSAL, Neighborhood Health, and Neurorestorative. Before we get started, I just want to let people know you've been emailed an evaluation. Your feedback is very important to us, but it's also your ticket to your CEU. Please fill it out completely with your name and what CEU that you are seeking, and return it to Richard at biari.org so we can easily process that CEU. It'll take approximately a week. This session is being recorded, so it will show up on our YouTube site in about a week or so as well. Participants who signed up for the entire series will receive their CEUs in November when the last session happens. So just to let you know as well that any questions that you have, we have some Q&A time at the end. Please type that into the chat box and we will go over those questions with Dr. Sizer at the end. So I'd like to introduce to you today's speaker, Dr. Caroline Sizer. Dr. Sizer is a physiatrist practicing in Rhode Island and Massachusetts and is board certified in both physical medicine and rehabilitation and brain injury medicine. She also serves as clinical faculty at the Warren Alpert Brown Medical School and Tufts Medical School, educating medical students and residents. She received her bachelor's degree in neuroscience at Brown University and her medical degree from UMDNJ, Robert Wood Johnson Medical School. She completed her preliminary internship in internal medicine at Brown Medical School in Providence and her residency training, where she served as chief resident at MedStar National Rehabilitation Hospital in Washington, D.C. She then completed her fellowship training in Richmond, Virginia, at Virginia Commonwealth University and Hunter Holmes McGuire VA Medical Center. Her work after fellowship has included medical directorship of acute inpatient brain injury care programming across a 4-hospital acute inpatient rehabilitation hospital system in New Hampshire, as well as the development of Lifespan Concussion Care Center here in Providence. Her most recent area of clinical focus has been in building robust interdisciplinary spasticity care options for survivors of central nervous system injuries that cause spasticity, such as brain injury and stroke in Rhode Island and Massachusetts. Welcome, Dr. Sizer.
Thank you. So I'm going to begin my talk called The Plateau in Progress. Let me share my screen, and thank you for that introduction. All right. Share. Okay. Put in presentation mode. Can you see my screen? Okay. Okay. And let me move this to the side. There we go. All right, A Plateau in Progress, the impact of spasticity on functional recovery after brain injury and stroke. First, for disclosures, I don't have any industry relationships to disclose, but I am employed by South Shore Physiatry and Spasticity Management, LLC, which is a dedicated and specialized tone management clinic in Braintree, Massachusetts currently. Roadmap for the presentation. So first we're going to talk about what is spasticity, go over a definition. How does spasticity present in brain injury and stroke? What is the impact of spasticity on function, health, wellness, quality of life, and caregiving challenges after brain injury and stroke? As well as treatment options and considerations that are unique to brain injury and stroke survivors. Lastly, we'll finish with a survivor story that illustrates the powerful effects of multidisciplinary care for spasticity management, and some closing thoughts. All right, so let's start with what is spasticity. So spasticity all starts with an injury to the brain or spinal cord, or we call it the central nervous system, which causes something called an upper motor neuron syndrome. This is a syndrome in which there's a constellation of sensation and movement disorders and signs that cause muscle hyperactivity. You'll also hear it referred to as hypertonia. Examples of conditions that cause spasticity are traumatic brain injury, anoxic brain injury, stroke, multiple sclerosis, cerebral palsy, and spinal cord injury. So hypertonia causes the muscles that are affected and those joints they're associated with to become very, very tight and can often be extremely painful. And it makes them very difficult to move through their range of motion. It's a type of spasticity, a type of overactivity in which there is a velocity dependent increase in resistance to you stretching that limb through its range of motion. This is different from other types of hypertonicity like rigidity, where the speed of movement through that range of motion does not seem to impact the degree of resistance that you get through the passive range of motion. Spasticity is unique in the sense that it is velocity dependent. So if you slow things down, it gets easier to move the limb. If you speed it up, the more resistance you're going to get. So let's talk a little bit about spasticity in brain injury and stroke specifically. It is actually more common than one might think. There's a prevalence of about 42.6% documented in stroke survivors, and it can be as high as 50% in individuals with severe TBI. It is rare in mild TBI, but can occur in moderate traumatic brain injury in about 17% of individuals. But this is primarily something that we'll see in severe and very severe TBI and stroke. In very severe traumatic brain injury, in which individuals have a disorder of consciousness, which is otherwise known as a coma in layman's terms, spasticity occurs in almost 90% of survivors. So it's actually very, very common. So how does it develop? Why does this even happen? Well, spasticity is something that develops in the course of recovery and neuroplasticity. And neuroplasticity is the way that we rewire after a brain injury or stroke. So the nerves that remain try to take over the jobs of the nerves that were lost from the injury. And we call that neuroplasticity. Sometimes it follows the expected path to regain normal movement, and sometimes it finds its own new path. Much like making a path through the woods, the more and more that we follow that path, the wider and more defined that path becomes. The same thing is true with spasticity and motor recovery. So it does take time to develop. It's not something that shows up immediately, which is why it often isn't discovered until later. So there are some classic patterns that spasticity will show up with in brain injury and stroke. In the arms, you can see a flexion pattern. So we call these synergy patterns because the positioning of the joints and the tightness of the muscles are in a pattern of multiple muscles assuming a certain position. So with upper extremity patterns, you can see the elbows bent, the wrists are bent, the fingers are curled. That's a very common presentation. And the shoulders are held with the elbows in towards the body. Another presentation can be with the elbows out, which is actually quite difficult for putting on clothes and actually getting through doorways in some cases, depending on how large the individual is or how long their limbs are. You can also see a different pattern where the elbows are completely outstretched, which also makes putting on clothes very difficult. Or you can see one pattern on one side and the opposite pattern on the other side that frequently will occur. In the legs, you can see a pattern where the knees are extended and fully stiff in an outstretched position, or the feet are pointed down, which is very difficult for trying to transfer or even position in a wheelchair, because the legs are completely stiffly stretched out. Or they can be in the opposite position where the hips are bent, the knees are bent, and the feet are pointed down, which again interferes with being able to sit properly in a chair, a wheelchair, or even the side of a bed or a mat. Or you can have the combination where you have two opposite patterns in either leg. So there is a relationship between spasticity and motor recovery after a brain injury or stroke. Some of my therapy colleagues are likely familiar with the very famous physical therapist, Dr. Brunstrom, who first described the stages of motor recovery after stroke and brain injury. And so she has the 6 stages. And one thing that we've learned over time is that you can, as one recovers, they can recover through all 6 stages, or they may find themselves arrested in one particular phase. And a common part of recovery and time in recovery when it's important to intervene is when spasticity occurs, to be able to progress someone from stage 3, where there's marked spasticity, to maybe stage 4 or stage 5 if we can. At any point in this process, a survivor may find themselves plateauing, so to speak, at any one of these stages. And so the goal of any type of rehabilitation program is to see how far can we push a survivor to be able to recover to their highest stage of recovery. And so what we see is, as motor control increases, spasticity tends to decrease. So these are also images from the very famous Copenhagen stroke study, which looked at 1,200 stroke survivors as they participated in the community intensive outpatient stroke program. And what you see is a similar pattern to what we've seen so far, where there is initial quick recovery of neurologic recovery, and then it starts to even out into a plateau again. And when you look at the timeline, you can see that spasticity and the degree of disability seems to correlate around the same time period. So around 6 months is when we really start seeing spasticity that interferes with function take hold. And what you can see is the prevalence in stroke survivors also increases to about 40% around that time frame. What you may notice on the graph is that by 1 year, there is a decrease in the percentage and the prevalence of spasticity after stroke. And that likely represents some people who have progressed through all of the Brunstrom stages and have recovered. So the time course of motor recovery and spasticity, as I mentioned, looks quite familiar, and these graphs are quite interesting. So one might ask, what can we do to keep this recovery going? How can we push the plateau further out? How exactly does spasticity impact function? That will give us clues on what we can do. So upper limb spasticity, it can interfere with dressing, reaching for targets, using utensils, or grasping objects. In the leg, it can interfere with using a wheelchair independently, or even sitting in a wheelchair, or walking, performing transfers, or being able to avoid falls. Spasticity is also painful. It can be extremely painful, and it can cause infections and skin breakdown if it interferes with the ability to access the skin to clean it. Spasticity also requires a great deal of strength, and I can tell you from personal experience taking care of folks with spasticity, to be able to range some of the joints that are impacted by spasticity requires a great deal of strength. And many of my patients who are able to actually move their limbs against their spasticity, they're extremely strong underneath their spasticity. So spasticity really does make it a lot harder for survivors and their caregivers to perform just their basic activities, such as transfers, toileting, bathing, and dressing. But there is hope. Things to consider for treatment and intervene. There are many people who have dedicated their careers to learning how to reduce the negative impact of spasticity on function, health, and quality of life for survivors and their caregivers. And it does require a multidisciplinary team approach. At the center of the approach is the survivor themselves, what their goals are, what they want to do, and what their priorities are. In addition, their caregivers are a huge part of the team and provide very good insights into what is absolutely the most important things to intervene on to help everyone reach their goal. Physical therapists and occupational therapists are amazing when it comes to spasticity care. The work that they do with stretching, strengthening modalities, weight bearing. I mean, there's so many different ways, serial casting, splinting. I mean, there's their work, and you will see in our case presentation the power of therapy for spasticity. Orthotists. So orthotists I like to think of them as engineers, but they're not quite engineers. They make braces, but they're custom made and with a lot of consideration placed on what the materials are of the brace, what's the fit of the brace, and combining orthotics or braces with therapy often achieves great outcomes for individuals who have spasticity after brain injury and stroke. Tone management specialists, so those are folks like me who treat tone to help survivors actually be able to benefit from their therapies, actually be able to fit in their brace, actually not have to worry about wounds and skin breakdown, reducing their pain, using the techniques that we have medically. And then when needed, it's important to recognize when it is time to involve a specialized orthopedic surgeon or neurosurgeon for further, more intense interventions for spasticity. So the first thing that we do for spasticity is exercise, and exercise is foundational. So first line treatment for spasticity is daily stretching, weight bearing, and strengthening exercise program. And this is something for all of my patients with spasticity. This is a lifelong maintenance program that they need to continue throughout every single day. Otherwise, we will lose ground. Physical and occupational therapy are crucial for helping survivors to learn these techniques, helping caregivers how to use these stretching techniques and not injure themselves in the process, as well as instituting interventions that can really progress patients to the next level, such as custom splinting for resting hand splints, for example, or serial casting. So for splinting, so splints and orthotics can provide both a prolonged stretch, particularly for a joint that is very rigid or very tight despite interventions with physical therapy and medications, possibly procedures too. If we combine all of these techniques with orthotics, we can get better outcomes. The materials of the splints matter in particular, particularly for individuals who are walking with spasticity. So the material of the splint actually really does matter. So what's pictured here is an ankle foot orthosis, or an AFO. It's made out of our preferred material, which is a thermoplastic polymer material that actually decreases the degree of spasticity. An alternative type of device that you may be familiar with or have seen is made out of carbon fiber. And carbon fiber has a wonderful property of being elastic and acting almost like a spring. But in the setting of spasticity, spasticity is fueled by reflexes and fueled by that spring-like material property. And so in many cases, we try not to use carbon fiber AFOs, and instead we'll use a thermoplastic design to be able to better control spasticity and improve walking for individuals who can walk, even if they do have spasticity. So working with a skilled orthotist for this, with a lot of experience with spasticity survivors, is key to getting a good functional outcome, especially for my patients who walk. So medications. So this is where taking a very specific approach for survivors of brain injury and stroke is particularly important. Cognition is a major concern with any of the medications that we take by mouth, because all of the medication options that we have to reduce spasticity that you can take by mouth have the side effect of sedation. And that's kind of antithetical to our other goals for brain injury and stroke survivorship, which is to optimize cognitive performance and independence. So we often find that the increased sedating effects, as well as it can slow processing speed, it can worsen an existing aphasia, and it can worsen attention and memory, and even can exacerbate underlying mood disorders from the brain injury or stroke, such as depression. So we're often looking for alternative options to manage spasticity than the systemic medications like baclofen, tizanidine, dantrolene, and diazepam. Now, some may have heard that dantrolene works peripherally, so it works on the muscles, and so it shouldn't have cognitive side effects. It shouldn't make your thinking cloudy. In theory, that is totally correct. I can tell you in practice, it causes sedation. It does cause cognitive changes, maybe not to the same degree as some of the other medication options, but it absolutely does. So I wouldn't say that that particular medication has any significant benefit over the others. You're still going to have the same kind of side effect profile. So the past 30 years have brought a lot of new innovations in spasticity care with regard to procedural management of spasticity. So now we're moving away from oral medications. The oldest intervention is phenol. So phenol is a chemical that was used as early as the 1960s to treat spasticity, particularly of certain body areas, by using the chemical property of phenol to burn the nerves to certain muscles to be able to decrease the spasticity in that muscle. Phenol has an all or nothing effect because it burns through the nerve, but the nerves tend to grow back because they're peripheral nerves. So the effects are typically temporary, but they do last quite a long time. They can last 9 to 12 months and occasionally more until the nerve eventually grows back. These procedures are very technically difficult and demanding to perform. Earlier on, when mixed nerves, so when we talk about mixed nerves, those are nerves that carry both sensation signals, but also send movement signals through the nerves to not only tell the muscles what to do, but it also has sensation to the muscles and the skin overlying. So those are mixed nerves. And when mixed nerves were injected, there was a higher risk of a complication of this procedure called that caused neuropathic pain due to inflammation of the nerve. So we've moved away from injecting mixed nerves more recently. And instead, the technique is more challenging because these are smaller nerves. These are direct motor branches from those original nerves to the muscles themselves. So it is technically more challenging, but the risk of neuropathic pain, so nerve pain after this procedure, has gone way down since we've really fine-tuned the procedure. It's still not done terribly frequently. It is something that I do in my practice, but it is not something that all physicians who practice spasticity management perform. But it is gaining a lot more attention more recently as our techniques have improved. So an oldie but a goodie. The past 30 years are particularly marked by the emergence of Botox. So botulinum toxins, the first one was actually Botox, but we also have Myoblock, which is a different form of botulinum toxin. And then Botox is kind of related to the other two options that we have now for botulinum toxin A. So its cousins are Dysport and Xeomin. So if you've heard of any of these are the 4 botulinum toxins that have been approved for treatment of spasticity and cervical dystonia. So it's important to know a few things about botulinum toxins. The first is that they do work as muscle relaxers at the muscle nerve connection level. So it has to be injected pretty close to that location with a needle. What's great about it is it can be just targeted to one particular muscle or certain muscle groups, but it doesn't affect the whole body. And as a physiatrist, and I'm sure many of my therapy colleagues can agree, sometimes spasticity can be helpful in certain cases. And so being able to pick and choose where you want to reduce the spasticity and where you want to leave it be is a nice feature of this intervention, particularly when we're combining it with therapies to achieve certain specific functional goals. The risks are, we're using a needle, so there's a risk of bleeding, infection at the site, soreness at the injection sites, and then there's a very rare risk of distal spread of toxin. And so that's if the medicine gets into the bloodstream and travels to other muscles, such as breathing or swallowing. It's quite rare, but it is a concern because breathing and swallowing difficulties aren't that uncommon in brain injury and stroke. So we always want to make sure we're using excellent technique, and it's typically done through at least one or two guidance methods. So some people will use ultrasound, others will use EMG, which allows you to listen to the muscle with the needle acting like a little microphone. And then the third is with electrical stimulation, where you give a little impulse to the muscle and the muscle contracts. That way you know you're in the right muscle. So it's very important to use some kind of guidance to make sure that it is safe. So, and it doesn't work immediately. That is the one thing that I wanted to mention. It takes about 1 week to start to work, and then botulinum toxin for spasticity tends to reach peak effect at 1 month. So it's not something that can be done on an emergent basis, for example. So moving on to the next level up for spasticity management that preserves some cognitive function. So this is another option that I'm thinking of when I'm seeing my patients who have brain injury or stroke and severe spasticity. So intrathecal baclofen has been around for now, oh my gosh, almost 30 years. And so it's been around for a while, and it's gone through a lot of improvements over the years, and it's a very safe and powerful intervention for spasticity now. It's completely revolutionized how we treat severe spasticity, particularly in large body areas impacting the legs and the trunk. So what it is it takes baclofen, which we mentioned earlier as it's an option that you can take by mouth, but it works at the level of the spinal cord. So what we can do is if we put the medication into a pump and put a catheter right at the spinal cord, we can use much, much, much lower doses and only put them at the spinal cord where it's going to act. This preserves your ability to focus on cognitive goals while also treating spasticity. So it can be controlled with a programmer on outside the body. So this is an entirely inside the body system. It does need to be placed by either a neurosurgeon or a spine physician who is trained in how to place them. And there are a couple of safety concerns just to keep in mind with any kind of device that we would implant. The first is the risk of infection. The second is the risk of the pump malfunctioning in some kind of way. So anyone who's taken baclofen or prescribed baclofen or known somebody who's taken baclofen is probably aware of some of the concerns with stopping baclofen abruptly. So there's a risk of seizures, there's a risk of rebound spasticity. But when we're talking about doses that are directly on the spinal cord, these are powerful, powerful doses. And so intrathecal baclofen withdrawal is a much bigger concern than even the withdrawal that we would see with oral baclofen, because the consequences are quite severe for acute withdrawal. So making sure that the refills are on time, that if there's any concern that there's a problem with the pump, you know exactly where your surgeon who placed the pump is, where the ER is that they are affiliated with, where the ERs are that have programmers to be able to interrogate the pumps, and being able to contact your tone management provider who manages your pump in the event of an emergency is extremely important if you do have an intrathecal baclofen pump. That said, it's still extremely rare. What's a more common problem that I see in my practice is subacute withdrawal or just treatment non-response. And usually that's either due to a tiny little crack in the catheter, or it could be from a granuloma formation. There are other ways that there could be problems with the pump that do not cause acute withdrawal. But it's important to know of the side effects and the potential emergency situations and what you would do in those situations. Nevertheless, this intervention has been completely life-changing for many of my patients and many survivors with severe spasticity. So moving on to something even more invasive would be something like a selective dorsal rhizotomy, which is a neurosurgery in which spasticity is reduced by selectively cutting sensory nerves as they reach the spinal cord and dampening the spasticity that way. We typically don't use this intervention all that often in adults with stroke and brain injury unless it is for palliative purposes where the spasticity is so severe that we're just trying to have some pain control and be able to prevent complications from very, very severe spasticity. There's also a newer technique that's gaining some traction called selective peripheral neurotomy, which is a similar process to phenol injections, except it's a microsurgery where a neurosurgeon will actually cut the individual motor nerve branches to individual muscles. And after that, the spasticity is treated and the patient can begin their rehab program. It does have the benefit over phenol in that it does have a wider number of muscles that can be addressed with this intervention. But it also has the downside of it's a surgery. Then the last intervention has been around for quite some time, which is tendon lengthening surgeries, which are typically done by orthopedic surgeons or neuroorthopedics. And so the way that these procedures work is I have an example of an Achilles lengthening surgery. They'll lengthen the tendon by actually putting nicks in the tendon in an alternating fashion so that when the tendon heals, it'll be in an elongated position. And that way you can treat the deformity that's caused by the shortened muscle. So putting this all together, because this is a lot, and we have some powerful tools to apply to spasticity, I wanted to use this patient survivor example from a case that's been published in the past year that demonstrates how important it is to treat severe spasticity, particularly in the context of very severe traumatic brain injury, in order to get the best functional outcome and quality of life for the survivor. So I wanted to show how these techniques work and how in a multidisciplinary approach really does impact the patient. So this particular survivor was a 25-year-old man at the time of his injury. And he was in a disorder of consciousness. So he was in a coma at the time due to a very severe traumatic brain injury that he sustained after a fall several weeks prior to this presentation. He had severe spasticity affecting all 4 limbs. And you can see that his legs have assumed the bent position where the hip is bent, the knees bent, and then actually the hips are crossing. And what's harder to see in this image, but is the case, is his arms actually assume opposite positions with their tones. So the right arm is held out in extension and the left arm is held in a flexion pattern. So this is extremely painful. He cannot sit in a wheelchair with this positioning. It is extremely difficult to perform just basic cares or keep the skin clean. So this is on maximum dosing of tizanidine and baclofen. So this is how his spasticity presents. So with maximum dosing of tizanidine and baclofen, that absolutely interferes with someone's ability to emerge from coma and regain consciousness. But pain from spasticity also interferes with that process. So we need to find a balance. So the next step, the first thing that we could do that works immediately and is a powerful intervention is our old school option, phenol. So phenol chemoneurolysis was performed on both legs to try to open up the hips and loosen up the knees. And this is typically, in this particular case, we're always considering, okay, we're going to do physical therapy and what are options for doing prolonged stretch. And the best option is with serial casting. So the main goals were to regain enough range of motion so that he could be upright. Upright positioning is so incredibly important for coma stimulation, and being able to be upright in a wheelchair and go places. It was also to ease the difficulty of caregiving, particularly with managing the perineum area. I mean, to be able to control, to reduce the risk of pressure wounds and skin breakdown that could cause further issues such as UTIs that would further interfere with someone's ability to emerge from coma. Now this is the power of therapy. So I just want to take a moment. Can we just take a look at the before and after photo? I mean, it's just amazing what my colleagues in physical and occupational therapy do. It's amazing. So this was after physical and occupational therapy began with stretching, strengthening, casting, splinting, working on upright positioning. And this was after some Botox as well. So you can see some of the work of our of the therapists with, the custom resting hand splint as well as serial casting on both legs. But he still was on maximum doses of tizanidine and baclofen to achieve this. So botulinum toxin injections were used for his arms to get that elbow out from a fully outstretched position and to be able to regain some range of motion in its left arm. But in addition, the intrathecal baclofen pump was trialed and placed, and he woke up after tizanidine and baclofen could be weaned. So this is a clear example of balancing spasticity care with cognitive goals. And for this particular patient, it brought him back to his family cognitively. So it's a powerful, powerful set of interventions that could only be done by a team. So with that, I just want to close with emphasizing the fact that spasticity care is a team sport. It does require a lot of access to multiple different people with very different skill sets, physical and occupational therapy, tone management, and splinting. And these interventions can break through even the most stiff of plateaus, such as that patient that we saw who hadn't even progressed through the Brunstrom stages because he was stuck, not only with severe spasticity, but also in a disorder of consciousness. So he broke through even though he was technically at a plateau. And these are my references. And I'll open this up for some questions.
Wonderful. Thank you so much. I find it fascinating. I've always heard the word spasticity, but it was nice to have it explained and see how technical and it all is, and the strides that everyone's making currently. If you have a question for Dr. Sizer, you can put the question into the chat box. Before we do that, I just want to remind people to please complete your evaluation and send it to Richard at biari.org so we can get your CEUs processed as soon as possible. Let me look at the chat here. Does baclofen work on upper, oh, sorry. It's just,
sorry.
That's okay. Does baclofen work on upper limbs as well?
So yes, it does. If you take it by mouth, it does not as well with an intrathecal baclofen pump. Some patients of mine who have a higher catheter tip level, who can kind of choose which level with the neurosurgeon. Some do notice a mild benefit, but usually if it's still very severe spasticity in the upper limbs, I'm having to address that with botulinum toxin or phenol, depending on how severe it is.
Any other questions for Dr. Sizer? I have a question. Just like where in Rhode Island do people get services for spasticity?
Sure. So there are a number of places. So in Rhode Island, intrathecal baclofen care is primarily done at the spine center at Rhode Island Hospital, but there are individual providers as well. So some of our neurologists in the area manage intrathecal baclofen pumps, as well as the physiatrists down at Vanderbilt Rehab Center. So they have actually a pretty good pump program down there as well. And the physiatrists down there actually kind of run it. And they also do botulinum toxin injections there.
Thank you. There's one more here. How far regression would you see on a patient who is non-compliant with stretching and daily exercise?
It can really go back to pre-treatment levels, especially if, let's say, the classic example that I run into is my patients who need botulinum toxin. And so botulinum toxin lasts about 3 or 4 months and then it wears off. None of our treatments are permanent, so to speak, and there's a benefit and a risk to that. The benefit is you can always kind of tweak it to what your goals are at the moment. The drawback is that you have to repeat it. But at least in 3-month increments, you can choose how you're going to manage the spasticity. So for a lot of my patients, if they fall off the wagon with their stretching and their weight bearing and their splinting between Botox sessions, what we'll find is that the Botox starts to seem to have less and less effect, even though I'm using the same doses and the same muscles, same techniques, same guidance systems. That could be for one of 2 reasons. The more common is that we've fallen off the wagon. A more rare potential reason these days than earlier in Botox's or botulinum toxins history is if you develop neutralizing antibodies. So we kind of avoid that by spacing out injections at least 3 months apart. So if you imagine botulinum toxin is a protein, and if you are exposed to a protein, much like a COVID vaccine, for example, your immune system will start to recognize it. But it needs another go to be able to really know that this is an outsider, I'm going to attack it. And so if that is represented before 3 months, there's a much higher risk that your body's going to recognize it and form neutralizing antibodies to the medication. And so that is another very rare potential reason for non-response to the medication. But the more common reason for a decline in response is kind of falling off the wagon with stretching. But the good news is if you get back on the wagon, we can do the Botox and things will, we will often do like once a year, every couple of years, a booster of therapies to kind of review a lot of these things if it looks like we're regressing.
Wow, thank you. There's another one here. A 63-year-old man had his first stroke at the age of 14. His right arm and hand have been spastic since his first of 2 strokes. Is it possible for treatment after such a long time?
Yes. So what would need to be determined is how much of the deformity is something called contracture, which is a permanent shortening of the muscles, versus how much of it is spasticity. And I mean, I have a patient who had her injury in the 1960s, and she still derives benefit, but we've had to combine it with neuroorthopedic surgery for sure.
Okay. Are there any other questions before we close this morning? Okay. Well, we certainly thank you. This concludes today's session of Plateau in Progress, the impact of spasticity on functional recovery after brain injury and stroke with Dr. Sizer. We thank you for your participation and welcome you to visit our website at biari.org. You can also check out our YouTube channel for archived recordings. So thank you very much, Dr. Sizer. We certainly appreciate all the information and have the great rest of your day, everyone. Take care.
Thank you.
Bye.